Hi guys, good evening. I'm Dr. Jenny Andrus. I'm here at Orthopaedic and Spine Center. Sorry guys, this is my first time doing this on social media. I don't even do social media in my real life outside of work. So thank you guys though that are watching. I am Jenny Andrus. I work here at Orthopaedic and Spine Center. I'm an interventional pain management physician. So I see tons of peripheral neuropathy, and that's what we're going to talk about tonight. I miss doing this here in the office. Usually I get to see you guys and we get to talk and kind of put faces with names, but due to COVID, we're going to do it this way tonight. Go down to the comments, add your questions. I'm going to try to answer them as we go along. So if something isn't making sense or you have a specific question or you need me to flesh something out, feel free. Go ahead and let me know what's on your mind and I'll try to answer as best I can. Okay, let's go ahead and get started. All right. Okay, I told you guys I don't even do this in my life outside of here, so. All right, here we go. Okay, so peripheral neuropathy is a very common condition. I treat a ton of it. So we're going to pretend that you are all first-year medical students and we're going to do peripheral neuropathy 101 tonight, okay? So what does it really mean? It's a very broad term. Patients will tell me all the time, I have neuropathy. But really, what does that mean? So it's damage to the peripheral nerves. And we'll flesh out a little bit more what that means. But there's various causes, and there's some specific things we can do to diagnose what's causing it. And then if we know what's causing it, sometimes we can help and fix it, sometimes we can't. But there's lots of things we can do to try to help with the discomfort. All right, so the nervous system, 3 parts, okay? So you have the central nervous system, you have the peripheral nervous system, and you have the autonomic. So the central nervous system is the brain and the spinal cord. That is not peripheral neuropathy. So if someone has a stroke and they have pain after stroke in a limb that was affected, for instance, that would be central pain, not peripheral, so it wouldn't be part of this conversation. Peripheral means from the spine out, okay? And then the autonomic is the part of the nervous system that controls things that you don't have to think about. Breathing, your digestion, your heart pumping. Some types of peripheral neuropathy can affect the autonomic nervous system, and diabetes or diabetic neuropathy is certainly one of those things. But we're not going to touch on that as much. We're really going to focus more on that peripheral system. All right, so this is sort of just giving you a schematic of what that looks like. And so when you go down to that peripheral, that's where we're going to talk about. And then if you look here where it branches out, autonomic and then somatic. Somatic is the voluntary movements of the skeletal muscles. That's the part that we're going to be talking about. But it also involves feeling to those as well. All right. Hold on now. Okay. I told y'all, I don't even do this in my real life. Okay, so looking at a nerve, and this is just kind of transection, nerves are made up of little bundles and these axons that transmit the impulse, which is a biochemical impulse, and so it's electrical. So your body really does work on electricity. And all of these little bundles come together and they have something called an epineurium around it. And when those all come together, they make that peripheral nerve. So inside the nerve, it can be a mixed nerve, meaning that it has both feeling parts to it and strength parts, or it can be only a strength one, or it can be only a feeling one. The blood vessels that support this are teeny tiny little blood vessels, and they're on the outside, and they have to dive down into there, and that's how they have to bring the nutrients and the things that the nerve needs to live. Most nerves have this coating around it. If you look down at the bottom where it says myelin sheath, that coating allows for basically insulation. So it allows that electricity to shoot down faster. So basic nerve damage, when we think of basic nerve damage, we think of damage to the axon itself, which is that little yellow thing down there at the bottom that's sending that impulse, or to the sheath around it, that coating, and that'll slow down a nerve. So in neuropathy, most of the time we're talking about those 2 types of things, and that's just what this picture is showing you. All right, so what causes neuropathy? That's probably the basics, right? We know what it is, but really what causes it, because what causes it is going to have a lot to do with what can we do about it. Endocrine, toxins, medicines, autoimmune disease, and infections. Those are kind of big lumps. Endocrine problems, Diabetes is the most common, and it is one of the 3 most common causes of peripheral neuropathy in the U.S. In diabetes, it's probably related more, at least in type 2 diabetes, to some of those metabolic things that go along with it. So if you're diabetic, your doctor probably talks to you about your heart, they probably talk to you about your kidneys, they talk to you about blood vessels and blood flow to the legs, and you worry about cholesterol levels and that type of thing. Well, the same thing that's happening in those big vessels, in the heart or the kidneys, or down the blood vessels down into the legs, are happening in those little teeny blood vessels that are supplying applying the nutrients down into that nerve. So if those are getting clogged up, you can imagine that you would end up getting some nerve damage. Blood sugar levels are very important in that because they can be toxic to the nerves, high blood sugar levels. Now, in type 1 diabetes, so type 1 diabetes, people who don't make insulin, and type 1 diabetics you typically think of in people who get it usually younger in life. In those situations, it seems like controlling the blood sugar levels really tightly can help prevent prevent peripheral neuropathy or prevent progression of it. In type 2 diabetes, which is more common, and we tend to think of it as sort of more of that insulin resistance type picture, in those patients, blood sugar control is important, but it doesn't as consistently protect you from developing peripheral neuropathy or for peripheral neuropathy progressing. Okay, Tom wants me to talk a little bit about alpha-lipoic acid. I'm absolutely going to get to that. Stay with me, okay? Don't go watch television. Stay with me because I'm going to get to alpha-lipoic acid. All right, thyroid disease can be associated with neuropathy as well. Usually you think of very severe thyroid disease, not what most of us might have where you need a little bit of Synthroid because your thyroid's a little low. When you talk about toxins, the biggest one, and one of the 3 biggest causes of peripheral neuropathy in the U.S. is alcohol. Now, this does not mean those of us who enjoy a little beverage or 2 after work. We're talking about usually heavy alcohol use over a prolonged period of time. Heavy metals are associated, but one that I see actually pretty common here dealing with a veteran population is Agent Orange exposure, and that can be associated with it. When we look at medications, there are a long list of medicines that can be associated with it. I mean, you'll even see like your statin drugs, your Zocors, and that kind of stuff on the list. But the biggie is some chemotherapies. Not all, okay, but some chemotherapy drugs absolutely are associated with it and can cause a pretty nasty peripheral neuropathy. It might save your life, but then, there's side effects later on. Autoimmune disease, lupus, rheumatoid arthritis, we see a fair amount of that. Infections like HIV can cause a really bad neuropathy, very painful bad neuropathy. Lyme's disease can be associated with it. One that's not on this list is kidney disease. End-stage renal disease, people on dialysis are at higher risk as well. All right. Now, there are some hereditary ones, and people kind of are questioning about that a lot. There's one Charcot-Marie tooth disorder. These are things, though, usually if you're older and you're coming to me and this is something that's just developed over the last couple of years, it's probably not one of these hereditary peripheral neuropathies. Most of the time folks know about those. They've seen them earlier in life. Mom and dad oftentimes have them. Vitamin deficiencies, you'll notice your doctor when you say, my fingers are numb or that type of thing, will usually check you for your B vitamin levels. Vitamin B12 is the most common one. Cancers can be associated with neuropathy. And then we get down to burns and compressions. Those are things that you obviously know, when those have happened. But if you guys see that word idiopathic down there, that's doctor speak for we don't know, which is unfortunately about a third of the time in peripheral neuropathy, is we just really don't know what the cause was. Hopefully we'll get better at that. But with that idiopathic neuropathy, you still need your doctor to rule out those other things and make sure it's not related to diabetes, it's not related to kidney disease, that type of thing. Now here's this whole long list here, and I'm not going to belabor that because this is only a few of them. I mean, when you really look at the list of medicines that can be associated with neuropathy, it's very, very high. All right, so normally when I have you guys here, I get to ask this question and see if any of you know it, but if you've heard me talk before, you probably do, but what do you think is the most common cause of neuropathy worldwide? I'll tell you. Normally people say diabetes, chemotherapy, or alcohol, okay? But it's leprosy, which is fortunately not something that we see a lot of here in the US. So that picture tells us again how fortunate we are to live here. So I've already hit on what are the most common causes of neuropathy in the United States, but in case you weren't listening, it is diabetes, alcohol abuse, and then that idiopathic, we really don't know. Now, most of the studies in peripheral neuropathy are really going to be based on the on the diabetic peripheral neuropathy, not on the alcoholic and not on the idiopathic. So we have to sort of extrapolate a lot of our information, and that is sometimes good, but not always, because we're starting to see that there's stratifications of that, and neuropathy that's maybe caused by a different issue may not respond as well to the same type of treatment. But as of right now, most of the medicines, and certainly the medicines that have FDA indications, are indicated for diabetic peripheral neuropathy. And if you have some other cause, your doctor sort of is extrapolating back and assuming that it'll work for your type as well. All right, so we talked about those blood vessels already, so I won't belabor that. Now, let's hit on the diabetic, because it's the one that's so common. So when you say distal symmetric sensory motor, what does that mean? And that means that it starts at the end nerves, like at the tips of your toes and tips of your fingers, and then works its way back. As the nerves get away from the body, those nutrients actually have to make their way all the way down, all the way out to these little teeny nerves. So you can imagine those little teeny ones that are furthest away from the central part of the body and are supplied by the smallest little blood vessels are going to be the most susceptible to damage. It usually starts in the toes first, and then it usually goes to the hands later. That sensory motor means it affects the feeling part and it affects the strength part. Now, usually it'll start affecting the feeling part first, and you'll see something called small fiber peripheral neuropathy. So that means little teeny nerves, not the big nerves. That's usually when people just say that the tips of their fingers feel a little raw, or the tips of their toes just don't feel quite right. That stocking glove distribution means exactly that. It means it's like that feeling is the whole area of where your sock would be, or the whole area where a glove would be. It doesn't really favor one area. So a lot of times, actually, I'll see folks and they'll have had carpal tunnel really badly for years, and they'll say, "Oh, no, Dr. Andrus, don't worry about that. That's my neuropathy." And I'll say, no, that's in the distribution of one nerve, which is the median nerve. That's not your neuropathy. And they'll go, "Oh, I just thought, if I had numbness in my hands and I have diabetes, it's got to be neuropathy." So if it doesn't cover all the fingers, if it doesn't seem the same in both legs, there may be something else going on that we need to look at. Now, radiculopathies are different. So radiculopathy is pinched nerve in the back or in the neck that causes that pain, that sciatica type pain that goes out into the arm or leg. In diabetes, you can get that without having compression of the nerve. And that's something called diabetic amyotrophy that usually affects the upper part of the lumbar spine. So patients will have really bad pain in their thigh or their hip and will get MRIs, and their back won't look too bad, but it'll be just the diabetes that caused it, or in the thoracic spine, so in the mid-back, kind of like radiating around. Now, don't assume if you have that and you have diabetes that's thoracic radiculopathy from diabetes. That can be shingles. It can be other things too. And then we have those autonomic things, and that's the gastroparesis, that's that slow stomach, difficulty with your bladder, erectile dysfunction. Those are things that go along with, again, those small nerves being affected. So when we get to the diagnosis part, we say, okay, you think you might have it. What are we going to look at? Of course, I'm going to talk to you because your symptoms are most important. Your medical history, have you had diabetes? Have you had cancer? Have you had chemotherapy? Have you had some toxin exposure? Mom, dad, brothers, sisters, those types of things are going to be very important. Your physical exam findings are going to be important because even though oftentimes patients feel like their fingertips are numb, when you touch them, everything feels fine. They'll say, "I don't understand. How is it numb? But it feels fine when you touch it, but it feels a little different when I touch it." But then you look at some patients and they'll have atrophy of muscles. And so if you look down at your hand, and so say if you turn your hand up and your palm up and you look at it, this right here where your thumb is, this should be kind of big. And if you move your thumb up and down, you should be able to see kind of a lump of muscle there, okay? If that muscle is flattened, then I get worried. If you turn your hand this way, and I know it's kind of hard to see, but right in here in my thumb, I can see the muscle. If I move my thumb around, I can see a muscle kind of moving in there. If you don't see anything in there, that starts to make me question too, is the neuropathy getting bad enough that it's killing off the muscles? Blood tests are not, there's no blood test that says you do have peripheral neuropathy or you don't. We don't have that kind of blood test. But what we do that for is to rule out or exclude other causes. So if I do blood tests to look for endocrine problems, that kind of thing. Then we do something called electrodiagnostic testing, and I'll go over that a little bit more. That's the EMG nerve conduction study. And then sometimes you'll get skin biopsies. Sometimes you'll get even nerve biopsies. Very rare. That's usually only done in the neurology setting and when someone has something really strange that we don't know what we're looking at. All right. So if you've had an EMG, you know what I'm talking about. But a nerve conduction test helps us look at that large fiber peripheral neuropathy. So not the teeny tiny fibers that are just affecting the skin feeling, but the bigger fibers that are affecting bigger areas of feeling, as well as the strength portion of your nerve. So what we do is we stimulate that nerve and we record its response. And it gives us this kind of waveform, and I can look and say, okay, how is this normal or not normal? Where is it slowed or not slowed? The second part, we put a little needle, and this is a fine little teeny needle, into the muscle. And so your muscle has normal electrical activity. That's how it works. And that electrical activity can look abnormal when you have neuropathy. You can have these when the muscle should be quiet and nothing should be going on, you'll see all these waves going on the screen. And that means that the muscle has gotten irritated. It's lost some of its ability to do what it needs to do because the nerve isn't sending that signal in correctly to it. All right, so you know what it is. You know how to diagnose it. Moving on, okay? Now we're at peripheral neuropathy 102, okay? So now we got to figure out how we are going to treat this thing. Now, because there are different symptoms, one thing isn't going to get it all, okay? Most important is prevention, right? Ounce of prevention worth a pound of cure kind of thing. So if there's something that we can do to keep a person from developing neuropathy or keep it from getting worse, then that's going to be number one, okay? Now, goal is we want to improve nerve function. And as we're going to talk about, and particularly when we talk about the alpha-lipoic acid, is most of what we do actually does not improve nerve function. We're going to talk about positive and negative symptoms a little bit, and then some of the secondary complications. All right. So symptoms, we base that on positive and negative symptoms, okay? So positive symptoms means there's the presence of something abnormal. Negative symptoms means there's the absence of something that should be there, right? So positive symptoms. People tell me all the time, I do not understand how my fingers are numb, but it hurts. I don't understand how my foot, it feels cold to me, but when my husband touches it, it's not cold. That's that kind of weird nerve stuff. So people say it's pricking, it's tingling, it's stabbing, it's jabbing, it feels freezing or cold. Sometimes it's very sensitive to the touch. So some people with neuropathy, they're like, I just can't stand to have shoes on, I can't stand to have socks on. Your muscles can cramp and twitch. A lot of patients they'll say, my feet are numb, I don't really care, my feet are numb, but I wake up all the time with these bad cramps in my feet. And then if there's the autonomic nervous system is involved, then you start talking about things like low blood pressure if you sit up too quickly, and intolerance to heat, and bowel and bladder problems. The negative symptoms are where you start to lose sensation, you have poor coordination, poor balance, muscle weakness, muscle wasting. So when I'm standing, this is hard to do on this little screen where I can't show you guys when I'm standing, but if I'm standing up, okay, my brain gets information from my feet as to where I am in space. So without me having to think about it, my brain automatically knows where my feet are. If I don't have good nerve function, my nerves can't get that that feeling quickly up to my brain, and my brain can't then turn around and quickly send to my body to tell me to adjust, I'm going to lose my balance. I'm going to have poor coordination. What happens with that is the biggest concern is you fall. And you fall and you break a bone, and then we have a whole other set of problems. Now, when we're talking about that treatment, we talked about early on the underlying problem. That's the thing we really want to make sure we're doing. So are we controlling blood sugar? Are we correcting whatever deficiency there is there? If there's some medicine that caused it, can we get that off? If you have some autoimmune disease, are we treating that? All those things have to happen first. Most of the time, by the time a person gets to me though, those things have already been addressed and are being addressed, and we're really more dealing with symptom management. So when we move on to symptom management, we always want to think about non-pills first, okay? There's so many good things that have come out of pharmaceuticals, and there are so many bad things that have come out of pharmaceuticals. So what we do know is that there are a lot of things that aren't drugs that work. And we all want our doctor to kind of quickly give us something and say, hey, we're used to, you go to the doctor, you get a prescription, that should fix the problem. It isn't that way in chronic pain a lot of times. So really think about some of this stuff. Relaxation techniques, acupuncture, biofeedback, compression socks if you don't have that sensitivity, TENS units. Those things can make a lot of difference, okay? Don't underestimate them. But of course, that doesn't work for everyone, right? So Linda says, a special skin biopsy might provide a diagnosis and result in fewer idiopathic cases. Okay, so the issue though is that the skin biopsy doesn't tell you what the cause of it is. So idiopathic means I don't know what the cause of it is. So skin biopsies can help diagnose if the person has neuropathy, but it doesn't tell me specifically what caused their neuropathy, okay? So when we're talking about symptom management with medications, the over-the-counter stuff can work, okay? Tylenol and anti-inflammatories work for some folks. Capsaicin cream, which is that hot pepper cream over-the-counter, that actually has had some benefit in some small studies. Just be careful if you use that you wash your hands really well after. You don't want to touch your eyes or something. It really will burn, just like you've cut jalapenos and touched your face. Lidocaine containing creams are staples, and we use those a lot. Now when you get to medicines for nerve pain, they come typically into two classes. Some are some of the antidepressants, and some are some of the anti-epileptics or anti-seizure drugs. Not all antidepressants work for pain, and we're going to hit on that. So if you're on Paxil or Prozac, it's not going to do a thing for the pain. It may make you feel better, may make your mood better, make your mental illness better. It's not going to do much when it comes to the pain problem. Now, the tricyclic antidepressants are old-timey antidepressants, and they are very well studied in nerve pain, and they are first line. The problem is that they have a lot of side effects that tend to compound as we get older, and so we don't want to use them. People who have heart arrhythmias, people who have that orthostatic hypotension, like when you sit up too fast and you get, your blood pressure goes down and you get lightheaded. They can cause some constipation, some dizziness. So they're usually given just at night, actually, which is good because if you're having trouble sleeping because of the neuropathy pain, they can really help you. Desipramine, nortriptyline, amitriptyline are the ones you see the most. Nortriptyline and amitriptyline have been studied a lot. They sort of throw the net wide in terms of receptors that they hit, and that's probably why they work so well, honestly, is because they hit so many receptors. But we just have to be careful, and they don't mix with all medications. And so my neuropathy population tends to be older folks, over 60, over 65, and in those cases, tricyclics won't be my first line, but they certainly are well studied. Now, SNRIs are serotonin norepinephrine reuptake inhibitors, so that is like duloxetine, Effexor, Savella. Duloxetine or Cymbalta is the most well studied, and they're usually pretty well tolerated. Venlafaxine is Effexor that may potentially do something as well for pain. There's a couple newer ones that we don't have as much experience with in terms of them doing anything for pain control. Okay, guys, don't forget, if you have questions, to put them in the comments for me. You don't have to wait until the end. I'm happy to jump in and answer your questions, okay? Now, the anticonvulsants are probably where your doctor is going to go first because they're very well studied and they can be very effective. But this is my rule of thumb, okay? Nerve pain medicines have about a third a chance of working real well. Now, they may work to a degree past that, but about a third of people, they're going to work really well. And about 2/3 of people, there's going to be side effects. Now, that doesn't mean those side effects are going to be terrible and you have to stop the medicine, but about 2/3 of people are going to have side effects. So these are not cure-alls, okay? But they certainly help, and we definitely use them. Gabapentin and Lyrica are going to be the two that you see the most commonly prescribed. Gabapentin is Neurontin. Side effects are usually sleepiness, dizziness, feeling goofy, off balance, swelling. And so, of course, as we get older, we don't metabolize the drugs as well, and those things have to be considered. If you have kidney disease, these don't hurt your kidneys, but they're excreted through your kidney. And so if you have kidney disease, we usually have to limit the dose. Now, there are some other ones that are used kind of to a variable degree. Topamax or topiramate, that's usually much better actually with headaches than it is with nerve pain. And so I don't use a ton of it in nerve pain, but we can. Lamotrigine's another one, and carbamazepine is usually used in neuropathy of the face, something called trigeminal neuralgia. I don't use very much of it for peripheral neuropathy just because it has so many more side effects and isn't nearly, in my experience, as beneficial as some of the others. All right, now the opiates are your more traditional pain pills. They are not super effective, unfortunately, in neuropathy pain. The atypical ones probably are more beneficial, and those are the ones that have a little bit of action on the serotonin norepinephrine system, which is the same system that's impacted by the antidepressants, the tricyclic antidepressants. So Nucynta, Tramadol, Methadone are usually a bit more effective. Tolerance unfortunately develops, and so what happens is somebody is kind of ticking along and they're taking a couple of pain pills at night and they're saying life's good, it's really helping me, and then all of a sudden boom, it's not working anymore, and so now they're taking double the dose, now they're taking triple the dose, and even though the doctor's increasing the dose, the pain relief isn't getting better. And that is a really limiting factor, unfortunately, with the opiates. The side effects limit the use in everyone, like constipation, the itching, the sedation, and they're not universally effective. Just like the nerve pain medicines don't work for everyone, the opiates don't work for everyone. In fact, a lot of patients, the side effects of them are far exceed any benefit they get. So let's get to alpha-lipoic acid, because this is something that has been used in Europe for a really long time, and I recommend that people try it because in diabetic neuropathy, at least, there's only two things that have really been shown to provide benefit in terms of improving nerve function. So all these medicines we talked about are for those positive symptoms: the burning, the tingling, the painful numbness, the cramping. They don't do a thing about the fact that the nerve is damaged, and they don't help with those negative symptoms, meaning they don't improve your coordination, they don't bring back muscle, and they don't allow you to feel better or anything. So alpha-lipoic acid actually has been shown to do that. Now, over-the-counter doses, the side effect profile is really good. The only thing that you just need to be careful, because it can decrease your blood sugar a little bit, which is, if you have diabetes, that's a good thing, right? But I usually tell folks, check with your family doctor before you start it, just to see if they want you to adjust your medicine. A lot of times they'll tell you just to, watch your blood sugar a little more closely initially, make sure it does okay. The thing with alpha-lipoic acid is, I tell folks, give it a good college try. It's not going to work overnight, and it's probably not going to work in isolation. So just taking the alpha-lipoic acid and doing nothing else is probably not going to make any difference. But the alpha-lipoic acid, in addition to a lot of the other things we do, may actually be improving things. And then, and I don't think it's on this slide, but a structured exercise program over a year has shown to actually allow for sprouting or improvement in nerve fiber density and those things like that skin biopsy that there was a question about earlier. And there was actually shown to be some improvement in folks who are on a structured exercise program. So I usually tell patients, when something cures everything, it cures nothing, with the exception of diet and exercise. Okay, so every drug that's out there marketed, every supplement that's out there marketed, when it has a laundry list of things that it makes so much better, it probably really doesn't degrade anything. But that is not true of diet and exercise. It just seems we always come around to those two things making a huge impact in medical conditions. All right, well, let's move on to what we can do from an interventional standpoint, because this is really important, and I do a fair share of this for peripheral neuropathy. Neuromodulation, spinal cord stimulation. The idea behind this is that we stimulate at a spinal cord level to replace the pain signal with something that doesn't hurt. Vibration, tap, tingle, buzz. This is done initially as a trial in the office, and if it's successful, then it's put in permanently. There is a little generator battery that allows you to control it with a remote control, so you can turn it on, off, up, and down. Now, years ago, I just did a ton of it mainly for back pain and leg pain from patients who had bad backs or had back surgery and still had issues. Very successful with that. But for my neuropathy population, it helped, but they didn't love that tingling or vibration because, in your feet and you're trying to walk, that feels weird, right? Well, some years back, the advent of high frequency stimulation came out, and so this is and sub threshold stimulation, and so what this means is you don't feel it. It's not at an intensity that you feel it, but it's still able to block those pain signals. That was a real game changer for me in terms of my neuropathy patients, because now they don't have to feel it, but they're still getting pain control. So this is great. It gives us a chance to try it out in the office before we do it, and you don't get to try out much in medicine, unfortunately, before you do it. So for folks who've failed the other things, this is a really good way to go. So burning, Linda wants to know about non-pharmacologic treatment for burning mouth. I don't treat a lot of burning mouth, so I'm gonna defer that on to my neurology colleagues, okay? All right, so let's go on to prevention of complications, because this is just something we have to do, and it's a pain. When you add one more step into your life, it's one more thing to think about. But fall prevention when you have bad neuropathy is so important, because you break your hip, you break your back, and then we have a whole world of problems, and we don't want to go down that route. So gait aids, don't be embarrassed to use the rollator walker if you need to. There's lots of fancy ones now. Just go for it. Get rid of those throw rugs that are everywhere. Get rid of, wall walking. I know you guys do it in the house. You walk and you touch the walls, or you hold on to the furniture. Maybe in your house where everything's where you always have it, you feel safe doing that, but you're not safe doing that out in town. Use a gait aid, okay? And then balance training with physical therapy is super important, and I send folks for this a lot because it can really make a big improvement. Even if the therapist can't, they can't fix the nerve problem, right? They can't overcome the nerve problem in a sense, but what they are able to do is give you a lot of adaptive strategies to work around it to make life as normal as it possibly can be. And then please don't forget to check your skin. So this guy on the back has been way overdoing it with the heating pad. I see a ton of this. This has really actually damaged the skin. When you see this mottled, kind of look like marble on your skin from the heating pad, you're damaging it. So you've got to cut back on that. In folks who don't have sensation there, and not so much in peripheral neuropathy, but I'll see this a lot in people who've had back surgery and they don't have good sensation along their back skin, they actually burn themselves, overdoing it with the heating pad. So keep an eye on that. And then definitely watching your feet. It is so easy to get an ulcer and have it turn into a huge problem and ending up with, this is when we talk about people ending up with amputations and that kind of thing. So good shoes that have a nice wide open area that are supportive, and check your feet, because with neuropathy, not only do you not feel it and you get those ulcers and those type of things, but then you don't heal very well when you get them. And that's why a lot of times people end up having to have these big reconstructive surgeries and that kind of thing. All right. So I am wrapping up. So if you have questions, go down to the comments and hit me with any questions that you have or things that I can maybe elaborate on for you. All right, so, if you guys are being shy and you don't have any more questions, I'm going to take that as I just really explained it all really well, but I imagine there probably are a lot of questions. So especially if you have specific questions and you think you have neuropathy and you want somebody to talk to and see if we can flesh out a diagnosis for you, we'd love to see you here at OSC. You can give us your information, make an appointment with us, or you can call us 757-596-1900. We are doing telemedicine visits now. That's not for new patients. If I've never seen you before, I need to meet you in person. But for my patients that know me well, we are doing telehealth visits right now because of COVID. Hopefully that will go away soon enough and we'll be able to see everybody face to face again. But for the meantime, we're happy to do that, try to keep you safe. All right. Okay, well, there's no more questions. Y'all have a great night. And again, call me if you have any issues that you want to talk about with your chronic pain. Good night.